All right, so I'm going to talk today about in utero substance use exposure in children. As a child and adolescent psychiatrist, this became my journey actually as a clinician, and seeing how this impacted especially children in West Virginia and how it really changes the trajectory of a child's development. This is a completely different way of viewing how a child's brain is functioning, and how it may really truly impact the treatment that you see. And so I really want to utilize sort of a different approach, and sort of get people thinking beyond our traditional DSM-5 labels for these kids, to really understand this as a neurocognitive disorder, and how that may change and the treatment and needs of the child in front of you. And this has really been a paradigm shift for me. I'll share with you my journey. I came back to West Virginia in 2008. Rapidly started seeing lots of little kids, and many of them are ADHD and ODD and all the traditional things I'd learned. But within about 7 or 8 years, the effects of the opiate epidemic and the challenges in SUD treatment in adults began trickling down into kids. And I started seeing children that were wildly different than what I thought, is how I will say that. I was still calling them ADHD and conduct disorder or sexually acting out, but they were not responding to traditional psychotherapies. They were not responding to medications. They didn't even look the same, but there wasn't a good way to describe it. And I had a grandparent actually say to me, that I think really helped me reset and go back to the drawing board with what was going on with these kids, to understand them. And it was this brilliant grandparent that just accepted the child where they were. They said, I know their parent was using substances, and I just accepted that their brain worked differently. And I just decided to meet them where they were. And that was really a wake-up call for me, that maybe we needed to think about these kids differently than the traditional box that they got put in with some of the diagnostic labeling and treatments. And so I really have dedicated, I guess, my career and seen this change over time about the needs and assessment of kids. And the short version is, I do think this looks more like a neurocognitive disorder, and a lot of these kids end up behaving more like kids with autism or TBIs, and some of their individual needs and assessments and very specific cognitive differences that occur in a spectrum than any other current label. And I'm going to even propose to you a diagnostic consideration that does exist in the back of the DSM-5 for these kids, but I hope it will help you think about them differently as well, and understand their needs. I also want to just say at the beginning of this, I love working with this population, but I will say they're often very, very ill, and not recognizing the effects of in utero substances. Often children arrive in crisis, their families are in crisis, overwhelmed, things haven't worked. And so it is really, well, very challenging on the front end, and we'll talk about some very negative aspects of this. I also want to say my change in philosophy and treatment of approaching these kids differently has also changed me as a provider, and the why I play the long game, because I have seen so much success as well with these kids when we do think more as a community of providers, and we do think outside of the box, and we do view them in this way. We think about their medicines differently, their school needs differently, their therapy needs differently, and their family-based needs differently. And you can see amazing changes in these kids as well. And so there's lots of success stories I can share with you regarding this, but I do want to just preface this presentation by talking about some of the risks of not understanding this. And so I don't want in any way to come across as negative, although some of the information is more leaning that way, but it really implies a change in direction that can lead to enormous success stories if we reconsider this group of kids. So I just want to give that preface before we launch in. So we're going to talk about how substance use in parents affects children. And we're going to start by really talking about the impacts of alcohol. I'm going to use alcohol as a model for all the other substances, because this really becomes a disorder of the brain, and what impacts of the brain at which point in development have been affected that might translate to what you're seeing in the child in front of you. And we're going to spend the end really highlighting how important it is to tackle treatment from multiple modalities with these kids as well. Okay. So while a lot of this focus talks on the direct effects on the brain, and that's this part. There are other ways that we know substance use in parents can impact children. Certainly, there is genetic transmission. The risk of substance use disorders has some direct genetic links and increase the risk that a child will have their own substance use disorder. In fact, one of the highest risks of diagnosis of a child is for them to go on to develop their own substance use problem in adolescence and later adulthood. And there are many theories for this. There's kindling theories, there's genetic transformations. A lot of this ties into the reward mechanism and reinforcement pathways around dopamine that may be seen when you've been exposed, and how it may change your cravings or desirability and impulse control centers. So there is a direct effect of that genetics as well. The other part that's really critically important to understand is that substance use disorder being active in a pregnant patient or a parent creates a lot of lack of structure, both because the parent may be struggling with their own levels of stress. We often see substance use disorders as people self-medicating other problems, mood issues, PTSD issues. And so when there are lots of changes going on in a person's body or environment, they see an increase in cortisol. And we're going to talk about the cortisol, which is the stress hormone, is actually neurotoxic to the brain's neurons. And so it kills neuronal cells. And so the prenatal stress just in the environment and in the mom, that not only is it the substance that may be the child exposed to, but the stressful environment that might come with the substances, even prenatally, could be impacting the development of brains. And we see this same pattern playing out in kids in utero that have been exposed to a lot of trauma. It's the same pathways with adverse childhood experiences leading to psychopathologies, that high levels of cortisol are rewiring the brain, so to speak. So that is also actively happening often alongside this pattern. You know, the other thing to recognize about kids, especially after they were born, and we do know that even kids can hear things in utero and hear sounds and hear tone of voice. Again, affective changes in a parent, whether a parent's angry or stressed or sad, can still be reflected in how the brain starts wiring itself. We reinforce positivity, we build positive connections. If we reinforce negativity, the negative connections and firings get remodeled in brain development. And so that stress and reaction of the parent's affect and even tone of voice may be part of the transmission process. And finally, beyond just the biological elements, there are lots of stressors that come with substance use disorders. There may be frequent moves, lack of housing, unstable medical care, challenges with ups and downs and job placements or financially. All of these contextual stressors and changes can have both biological and psychosocial impacts that can be affecting that developing brain. So it is a very multifactorial process that could be happening. For those of you from West Virginia, you know that our state has been hit very hard in this regard, and this really does reflect my career. In 2017, we had a substantial gross increase in the number of children being removed from the home. It went from almost 700, I think, when I arrived in 2018 to almost 7,000 by the time this crisis hit. And so many of those children were being removed from their homes because of substance use. So not only were these children at high risk of having that in utero exposure, but they now had an environmental change, additional ACEs, high levels of cortisol, and new family members or people to care for them. And so this became a driving force in a lot of the crisis we see in children's mental health in this state. There again are those numbers that have gone up. This is an old number, but this is not. This is birth data, and this is birth data from 2022. So this is last year's birth data. So this is our state collects as part of Project Watch data on whether children were exposed at birth. So this is when they were born. So these are numbers that you are not going to see the impacts of for quite a while. We will talk about late effects of substance use. And by late effects, we often mean school age. These are the children born in 2022. 1 in 7 children in West Virginia are exposed in utero. Huge, huge, huge. That compares to the national average of 1 in 12. Neonatal abstinence syndrome, which reflects specifically opiates, is 1 in 18 compared to the national average of 1 in 140. And then if you look at our need with Medicaid services, and again, those populations that have additional needs, especially socioeconomically, we again see 1 in 12 of our Medicaid supported programming children being exposed. These are huge, huge, huge numbers that are going to continue to influence the needs of the children that reach us in practice and in our clinics years down the road. It's not always easy to know if in utero exposure occurred. And so you have to have, especially in this state, a high degree of ability to ask about it, because if you don't consider it, you won't know to look for it, or you may not know that that's impacting the child. And this could be hard information to get. Sometimes we rely on guardians or foster parents to give that information. They may say, I don't know if a mom used during a pregnancy, but I know she had a problem. It is hard sometimes to even get self-reports. People are embarrassed about their use. They're afraid they'll lose their children if they tell instead of getting help. And we can talk about that a little bit more, but you have to have a high degree of suspicion to go looking for it because urine drug screens alone and just asking may not be enough. It is helpful to look into as many records or things as you can. Right now, we've done a better job as a society at looking at what happens when you're born. So that watch data, that exposure data, when we talk about NAS, babies or ICU or NICU care, we're talking about early effects. Those are very easy to measure, right? Height, weight, head circumference. We can see an infant in withdrawal or not. We can gauge if they live or they die or they receive so many days of NICU care. But after they leave the hospital and after those first, few months of birth, they often get lost the tracking of medical outcomes and needs. And we often don't see these things emerge until a kid hits school. So often, we accept, that children are indeed a little more hyper, a little more wild, a little more intense, and we may not see some of the separations from more ill children until far later. And so it really seems to hit when kids hit school. And it becomes very obvious when they're sitting next to their same stage peers that they're not having the same behavioral outcomes or they're not having the same thinking patterns or school profiles. And this has become a crisis for our schools as well, figuring out how to serve these kids. And so this 5 to 6, 7 years down the road from birth is really where we are really trying to gauge more understanding and learning and treatment outcomes. So I am not going to talk about the early effects at all. My focus is really going to be on that later population as they start hitting psychiatric clinics, hit our emergency rooms, to really think about what a child that was exposed many years before might be displaying now. So as we talk about the exposure, there's some things that we need to understand, and this is where it gets really messy. This is where it also makes research and data hard. So you have to accept a lot of the nuances and that each of these children become very, very different in their presentation. Although we can talk about generalities, what child may present may depend on which stage of development their brain was affected. Was use only happening in the first trimester and then they got treatment? Was it only in the second or the third trimester? Was this parent exposed to a low continuous dose, or was the binge purge pattern more at play? And this is actually really important. We believe that, especially for opiates and parents that have received treatment, like with buprenorphine or some other type of medical treatment or even medications, that if you maintain a slow, steady, constant dose, that is much less risk to that infant's brain because they can adapt to those changes that occur. The binge purge on-off cycle of use, like large quantities here, actually triggers almost an inflammatory recovery response that could be just as problematic. And so we tend to believe that the binge purge on-off use may be far worse than a constant treatment use when we talk about exposure. How long were they exposed? Did this occur once? or did this occur every day? And then the challenge in our current world is we don't see much mono substance use anymore. Some of these early patterns with alcohol are just alcohol, but many of our cases of parental SUD cases today typically involve multiple substances. It may be alcohol, opiates, marijuana. Often it is very, very rare to just see one substance of use, which complicates that. So kids get exposed to different substances in different ways. And while again, there are patterns, they're not exactly completely the same. So this is just a refresher of the brain. This outer part is the cortical area. This is where we have a lot of the gray matter, the neurons. And each area of the brain controls other parts. Broca's and Wernicke areas conduct speech. Temporal lobe often is hearing. This area right up here in the front, right behind our forehead, is the frontal lobe. This is our brakes, our ability to stop and pause and control things. This is where executive functioning and planning and organization occur. This is actually the last area of the brain to develop and one of the most sensitive areas of the brain to substance use exposure. I'll show you some other pictures. We have motor strip areas, sensory experiences. The parietal lobe helps with visual spatial coordination. Occipital lobes help with visual and content. And we have this lower motor functioning. When substance use is involved, it tends to affect this outer area far more than it involves this lower area. And that's important because this lower area may control things like cravings and rewards, but all of this upper part, this upper cortical area, they're all connected to one another. So if an area gets damaged, its projection also gets damaged in its control. So you can see kids that have motor problems, sensory problems, visual spatial problems, and they may have all of them, or they only may have one part affected, depending on what part of their brain may have been impacted. But our brain is, and I'm going to use this analogy, our brain is like, I'm going to use a computer analogy. The brain itself is like hardware. It is built to take in information, process information, and put it back. The software are the things we're giving it. If we're talking to someone, if we're offering a clinical treatment, if we're offering a medication, that's our software. But the brain is the hardware. And we have to understand what the hardware is doing, what it's supposed to do, and what it may not be doing because of this exposure. And you have to think like a neuroanatomist almost when you think about this. And it doesn't have, but you know, this child in front of you may not be able to stop their hyperactivity. It's not something they really can control. It may be that hardware is broken, or this child has horrible sensory outcomes. They feel pain instead of soft touch. And they're misinterpreting it. And that's a hardware problem, not a software problem. And we have to differentiate that. This is the brain of normal development. And so you put this on top of any damage that might be occur. And when we think about an adolescent or a child brain, it's already not developed. This is good and bad news. The good news is because the brain is still developing well into the mid-20s, if we put the right type of interventions in, meaning we reinforce the good connections that exist and we grow that, we have hope that we can rebuild the positive circuitry. However, if we reinforce the negative circuitry, this problem can kind of continue. So we do have a lot of room for intervention. But in this slide, this is as the brain develops normally. This is a non-damaged brain. You'll see that frontal area behind the cortex is the absolute last to develop. This is the area that's often involved in ADHD and impulse control and reward systems, and it already is not fully developed even in a normal brain. And so part of what you have to understand in looking at these children is you have to know what's just the normal development that hasn't caught up with yet, and what might actually be that hardware damage. And I love this quote because even a normal adolescent brain is like a car that fully functions, but without that frontal lobe, you're missing the brakes. They just don't work. And remember, they just don't work even in a normal kid. So you take a little kid that is already struggling with that hardware challenge and you take the brakes away, you can see some wild, out of control behavior that needs a lot of services to help stabilize it. I'm seeing some comments in, am I getting any comments in the chat right there? I want to make sure everyone is following this part because I'm going to branch it all out from here. It's making sense? Okay. All right. So we're moving into alcohol, and I'm going to use alcohol as this model again to understand what a substance does to the brain, because we're going to use that model. You're going to see a lot of patterns in other substances, but we know the most about alcohol by far. We've known the challenges of alcohol in pregnancy for literally centuries. You go back to the age of Aristotle, you will see comments about women that were put in debtor's prison for debts, and they didn't have access to alcohol. And there were notes even then that women that had been addicted to alcohol, when they were indebted, had healthier babies because they weren't being exposed to alcohol then. We knew this existed. We knew it was a problem, but we didn't really understand it or have criteria. It wasn't until 1973 that Jones and Smith put forth this actual criteria about fetal alcohol exposure and syndrome. And today we call it a spectrum. We're going back to the spectrum being that how much, when, how often, to what extent, and how different each child can look. And we have referred to it now for alcohol as a fetal alcohol spectrum disorder. This is non-discriminatory. We know it affects all races, all ethnic groups. We have a prevalence, and again, depending on whether you're talking about the direct effects, and I'm going to talk about that, the full effect meaning criteria is about 0.1% of the population in the United States. If you talk about spectrum, it's almost 1%. So that 1 in every 10 children nationally is going to have meet this. And this has huge economic impacts. I don't think I need to tell people in West Virginia how strong substance use has impacted our economics, but people lose workforce capacity, they lose years off their lives, they often don't have full educational attainment. This is a huge societal concern, both for that developing child as well as the caregiver or parent that was affected. We have different ways to define this, and this kind of comes back to the challenge even in the medical categories, that you have to know whether exposure occurred or not, whether it was suspected. So you can have it meet criteria without exposure, with confirmed exposure, partial exposure, and then you get down in here into these bottom categories related to alcohol, where you actually see birth defects, so physical things. I'm going to really talk about the neurodevelopmental piece, and this is what happens to the brain as a result of the alcohol. So the physical effects are pretty well known. These are some pictures I'll show you just looking for alcohol exposure. We do not have the physical effects as well categorized in other substances as we do alcohol. So alcohol is the one where we have the most physical data, and they're very subtle. The first is the epicantral folds. Those are the folds on the inside of the eye, and the eye fissures being small, meaning that the opening is not as wide. And you may need to take calipers and actually measure these things to truly be able to gauge them. But you can look, you can get a flat nasal bridge. It almost looks like the thumb has been pushed into the top of the nose. It gets flat. The lip is a major sign. This philtrum, instead of having the ridges, is often smooth, and the upper lip is very, very thin. Have been defined as the key physical features. These are some children with confirmed fetal alcohol syndrome. And if you look closely, you can see some of these things. But I'm going to tell you, this is not obvious. I think these kids are adorably and cute. My first look at them would not be to think they had fetal alcohol effects. And so this is just how subtle it is. I will also say some of these things can still be there and not be fetal alcohol again at all. So it really comes back that you can't truly rely on the physical features unless they're there. So you cannot look, even in the absence of physical feature, it doesn't mean there's something going on. But even if it's there, it may not be readily identifiable. But you can measure them. This is a lip philtrum guide. The 4 and the 5, where you see the thinner philtrums and the thinner upper lip, is gaugeable, and a 4 or 5 puts you in the at risk for exposure category on the physical features. These are softer signs. This is a curved 5th digit, railroad, a hockey stick, a crease in the hands. This double ear crease is called the railroad track. Those, again, very, very soft, non-specific features of some type of neurocognitive physical effect. When we think about what specifically do you need to meet full physical criteria for this, that full 0.1% diagnosis, you have to have the short palpebral fissure, so the eye opening less than 10%, a score of 4 or 5 on the philtrum or the lip, your height and weight on your height weight chart in your pediatrician's office below the 10th percentile, head circumference below the 10th percentile. And if you are able to see some of those structural brain abnormalities, that would meet the full physical criteria for this disorder. As I mentioned, I'm not that excited about the physical stuff. This is the psychiatric stuff that really, I think, is more challenging. And I want to make sure I introduce these terms, because when we talk about looking at the non-physical features, we're often talking about caregiver and teacher surveys. So we're asking caregivers for what they see. And if you're a caregiver, you will know it is far easier to see the externalizing things. When the child is running around, hitting, throwing, jumping up and down, having a tantrum, that is far easier as a caregiver to see. We call those the externalizing problems. However, there are a lot of internalizing problems that happen as well. And those sort of more of the self-esteem, the depression, the anxiety symptoms. You have to know the child. That child has to feel safe. You have to have a little bit more observation and communication to pick up on these things. And then my final comment is they can all cause one another. So we see externalizing problems being mislabeled as internalizing problems. Internalizing problems can lead to external, and often both are present. In fact, a lot of times kids have an array of all of these, and you send surveys of behavioral data, they flag on everything just because the entire brain may be affected. But when we talk about some of the definitions about what substance use has been linked to, it's coming from these surveys. And so I want you to make sure you understand those terms. Okay, so this is a picture I really want you to understand, because this is kind of going really back to what is the biological etiology of this problem. So when we survey what are psychiatric outcomes in kids, do they get diagnoses from alcohol exposure? Almost 100% of kids get a diagnosis. So 87 to 95% get at least one. And I'm going to tell you, most of them get 2 or 3 minimum. Shouldn't be a shock, but again, that's thinking like the DSM. And I'm asking you to think more like a neuroanatomist and brain functional part as we talk about this, because when the substances, and alcohol in this case, is hitting the brain, it is affecting whatever is developing at the brain. It is toxic at the brain at the time it is hitting the brain. And so you are changing the way the brain looks and works. And you're changing those neurons. This is a picture on the left of what a normal 6-week-old infant brain should look like. Okay. You see those sulci and those ridges, all that gray matter that you see is that healthy brain tissue. Those dark grooves are the deep sulci, where all these neuron networks are starting to form. That's a healthy brain. This child died for something else entirely. On the right, again, is an extreme example, because this child died from fetal alcohol effects, but it is showing you what the brain is doing to the tissues. It is actually killing it. It is toxic. This is a toxic encephalopic sort of pattern. That frontal part, which is at the top of the screen, you will see, if you compare it, is the most damaged. And the reason for that is because that frontal lobe is the last to develop and develops into the 20s. It is the most sensitive to toxic effects. So any toxic effect, whether it's oxygen deprivation or substance, is going to affect that frontal lobe. So you see the impairment in this frontal lobe that controls our organization, our attention, our executive function, always being the most susceptible to that damage. And you see just gross tissue loss. The frontal lobe is absent in this brain, okay? But you also see other areas of the brain where there are less tissues, and you see it smooth. It's not as deep. You don't see all that rigid. It almost looks like a smooth plane, like you shaved it off, and that's a loss of neuronal tissue. And it's affecting the entire brain, but you're seeing areas of the brain that are being more affected. And it's not just the substances. Remember, I told you that alcohol is doing that. You're also having cortisol have that same toxic effect at high levels from stress that is also neurotoxic. So you're getting a double whammy, probably, of cortisol and the direct toxic effects of the substances contributing to this neuronal loss. And is this neuronal loss, that hardware problem that is making the brain lose its functional abilities? Those neurons that might connect to this are broken. Okay. So now we're going to step back out of our neuroanatomy shell. We're going to look at what that looks like when we go back to the DSM-5 and diagnostic stuff. So when these kids are showing up, if we're just using that DSM-5 book we have, what is it looking like? So what we're seeing is that people that have heavy use of alcohol are having nearly an 80% rate of those kids having problems with attachment. That could be reactive attachment disorder, but at its core, it's problems identifying, trusting, and feeling connected to their caregiver. That's 80% versus only 36% in light use. Now, if you have a child that also was removed from the home, lost their caregiver, you can have additional burdens from the substances, but enormous risks of attachment disorders in this population. Very high rates of mood and anxiety disorders. Almost 19% of alcohol-exposed children had depression versus only a normal rate of 1% in childhood. So again, the loss of that neuronal tissue also contributes to that loss of serotonin, self-regulation, self-soothing pathways that are meeting criteria for anxiety and depressive disorders. Remember that frontal lobe was gone. The brake was already not well formed because it was developmental, but now we killed it with the toxic effects. We see enormous rates of ADHD, ODD, and conduct disorder because we have taken away the impulse control, organizational planning, think it out part of their brain. I would say I think this rate is real low compared to my population. It is almost, but the kids that come to me are almost 80–90% impulse control problems. They are wild because they do not have that break or less break than they normally have. But it's not just that. It's not just the break on the physical piece, because remember all those connections, that frontal lobe connects back to help break and slow your thinking, slow your motor functioning. But because that frontal lobe also helps you with judgment and organization, sometimes they're not coordinating information from the visual world or the auditory world. And so what we know in these kids is when they see faces or they are given social situations, they are more likely to respond with perceived hostility in flight or fight mode and engage in aggressive physical solutions than able to cognitively problem solve it. Again, that's not because they're bad children or they're trying, but remember, the part of the brain that is still working is that deeper axes where you have the more animalistic sort of flight. Those mechanisms are not as affected by the substance use, the fight, flight, freeze effects that lead to problem solving. Those are less affected than those larger cognitive ones. And so some of the challenges in executive functioning are that the driver of that fight, flight, react behavior is still there, but the thinking part and the braking part of the physical control has been removed. And I'm going to get to this at the end, but these children look like they have ADHD. Most all of them get diagnosed with ADHD, but because this is different than biologically inherited ADHD, they respond very differently to medications. And I cannot say that enough. If you try to treat these kids that have no frontal lobe with high doses of stimulants, they will get more agitated. Their ADHD will not respond because you are going to pump in norepinephrine and dopamine that while normally would help an ADHD biologically affected child, it's not the same. And the kids that have biologically inherited ADHD, those neurons are still there. When you add dopamine and norepinephrine, there's receptors to respond to it and they get better. When you add all that norepinephrine and dopamine and stimulant to these kids, when the neurons aren't there, they get worse. They get agitated and they may get a little better at lower doses, but they don't have enough to respond the same way at the same dose as the other kids. And they look really, really different. So I really want to make that point because as someone who writes medications, I frequently see, well, we've tried everything for ADHD, it doesn't work. It's not the same type of ADHD. This is neurocognitively in your ADHD. It doesn't have the neurons. We have to think differently about how we treat it. So I really wanted to make the point. We'll do a little bit more of that later. We see very high rates of suicide in suicide attempts, very, very high risk of substance use, relative risk of almost three times the risk. And again, that goes back to some of that genetic inheritance. And we see massive language and learning problems. lower IQ, lower achievement. We see people falling more in the borderline, even intellectually, than we would have expected for their history. And we'll talk more about that too. And again, remember, it's because we're losing our neurons. We're losing our thinking parts of our brain. So this is the other part I really want you to try to remember in the grand scheme of things. In the very back of the DSM, this book here, and it's under the category of diagnosis. It's in the back called diagnosis for further consideration. So it is not an official DSM criteria, but it is for further understanding. They have put forth this diagnosis: a neurobehavioral disorder associated with prenatal alcohol exposure. And this is the definition that they have put forth. And I would just say this reigns home for what you see. So there has to be more than minimal exposure to alcohol. B criteria, we see impaired neurocognitive function. So we see some impairment in global intellectual performance, some decrease in IQ. We said that impairment in executive functioning, planning, organizing, behavioral inhibition, impairment in learning, memory impairment, impairment in visual spatial reasoning. That was all that damage to that cortical area. We see, and then criteria C, impairment in self-regulation, impairment in mood, behavioral regulation, attention deficit, impairments in impulse control. And so you can see what, without this diagnosis in the DSM-5, what do these kids get labeled at? And I have up to 16. I saw a kid with 16 diagnoses, but you can see how this one cause, in utero exposure of alcohol, has been linked to intellectual. So let's go through what we see: ADHD, conduct disorder, ODD. We see learning disorders. We see speech language disorders. We see ADHD. We see, depression, anxiety, PTSD. Kids get these laundry lists of diagnoses, which again are not incorrect, but they may not understand the true etiology that the neuron was destroyed, leading to how they control it. And this is where the treatment really becomes relevant, because you have to understand this part. And what I will tell you is not every child has impairment in every area, because each child is different. Sometimes they're areas of strength. And this is where you start thinking about how critical it is in your treatment approach, because you want to know where those strengths are. Because if we can build on the strength, we can still have time to build that success. Okay. Do you have any questions about this?
So where are they?
North, I think. And can you see it somewhere?
Okay. So in our foster care population, there are very, very high rates of this. This is old data, but probably has not changed so much that we see almost 17%. I don't know what West Virginia specific numbers would be. I would, again, guess that they may be higher. Again, we're still just talking about alcohol. So what do other drugs do? Now we're learning more and more about other substances every day. And so I'm going to present some of that data to you. Again, it's messy because lots of times we aren't seeing single substances being used. But what I'm going to tell you is this pattern that we're going to fly through from other drugs is not that different. They're still toxic, just still having very similar patterns to alcohol. The first one we're going to talk about is tobacco. We do not talk enough about tobacco, but tobacco is a mild stimulant, and we know that tobacco exposure causes substantial problems for kids as well. West Virginia has almost a 1 in 4 rate of women still using vape or nicotine, very, very high rates of tobacco use. And we know that even 10 cigarettes a day or 10 milligrams of nicotine a day, which is equivalent to that, increases the risk of ADHD. And again, it's probably that frontal lobe effects of toxicity that comes from that. We see the same pattern with learning. These are lower math and reading scores and digit span scores, again, being shown just from tobacco. These are pure tobacco studies. And so not only do you have physical effects of poor growth and hearing loss, higher rates of SIDS and breathing problems, you are more likely with just tobacco alone to have a 50% increased risk of 2 other psychiatric diagnoses and 3 times the risk to have a learning disability or fail a grade from nicotine alone. Again, frontal lobe, executive functioning impact. Marijuana, same pattern. We have several longitudinal studies that have looked at that. And again, high rates of impulsivity, hyperactivity, delinquency, impaired executive functioning. We see marijuana impacting depression. This is a study that said just from being exposed in utero to marijuana increases your risk of depression by age, I think it's age 10. Again, this is not anything the child did after they were born. There could be other stressors. This is with marijuana itself has been shown that. And, oh, I'm sorry, I jumped ahead. This is the IQ loss. This is IQ loss from marijuana, 6 to 8 points. This is the depression loss, higher rate of depression at 10 years in the child from in utero exposure. Again, it's the very same pattern. We are now seeing marijuana, especially with legalization, becoming a huge problem in the maternal fetal realm. We are seeing massive issues coming out of children from psychotic-like experiences, internalizing problems, externalizing problems, ADHD, social problems, decreased birth weight. And again, that decreased total intracranial volume and white matter changes. That's the destruction of the neurons again that we're seeing. So again, a very, very similar pattern with marijuana coming out. And again, this goes without saying, we should not encourage cannabis use during reproductive years. It is associated with substantial risk of the children having problems when they hit middle school. Marijuana also has been shown to affect the immune system, even at the RNA, DNA level. So these are become epigenetic changes built in that can be passed on to the next generation. We go to crack and cocaine, again, stimulants showing substantial risk. Now, this is interesting. This showed in crack cocaine that in that first 6 years, when we're measuring their growth and height and all that, we weren't seeing any problems. So we almost thought it was safe, right? Nope, they hit school. We are seeing substantial problems again coming from that frontal lobe, problems with attention, behavior recognition. When they scan the brains in adolescence, they're showing again lower gray matter, areas impacting with reward, executive functioning, same flags. Same thing with meth, higher rates of internalizing rule-breaking behaviors. Again, frontal lobe kind of effects there as well. And then opiates, we're learning more and more about opiates. A little different pattern sometimes with opiates, but still, these are kids that have been followed, identified actually as neonatal abstinence syndrome when they're born and followed forward. Much higher rates of disability reported, much higher needs for classroom therapies and services. Again, seeing this loss of IQ points. Again, look, it's almost the same, 6 to 8 IQ points being lost compared with normal population. That's a half a standard deviation. Poor motor outcomes. The motor outcomes are much worse, I think, in opiates than the other ones. And when you can't control, motor outcomes come from lack of control, right, of that poor executive functioning. And again, they are not getting better with time. One of the things I do want to point out, because I think this is really important, we, especially with the explosion of maintenance treatments for opiate use disorders, a lot of times I give this talk and people are like, well, what about Suboxone? What about methadone? What about giving people a medicine that you're saying causes problems? Well, again, we come back to that sort of fact that if we don't provide a substance treatment, people don't get better. When we look at abstinence-only models without something like medication-assisted treatment, the success of abstinent models is less than 5%. So we are setting people up for failure if we don't give them another option. And remember, that low constant dose exposure is always better than the binge and cycles of use. And if we give a low dose exposure and it stops their cravings, we might reduce some of the cortisol and that HPA axis stressors that are occurring from the use disorder outside of their world. When we give maintenance assisted treatments, they're more likely to get medical care and prenatal care. And they're also more likely to learn and reduce that stress. So they're not stuck in those drug-seeking behaviors, which lends other areas of things. So at the end of the day, 100% do I believe that maintenance treatment is safe and a better alternative, even for the children, because anything that helps the mother be healthier is going to help the child. But it's helping it on so many different levels that low constant dose is much less likely to cause a problem. Is it completely safe? Probably not, but it's safer than just subscribing the risks that we know that happen from absence models. And so as many of you have heard me say before, when we're thinking about treating pregnant women, we always have to ask, what's the risk of not doing it? And in this case, not giving women maintenance treatment for opiate use disorder has far, far more risks than even what we can say from the kids. All right, so as we look at this burden, we definitely see what it's done to our society. We certainly see that these youth and these children will go on to struggle with full attainment and education. They're more likely to be underemployed and have lower wages, and may have early use of substances themselves. And all of those things are always linked to higher healthcare and juvenile justice rates. And so it goes into how much as a society we have to come together. And while we've talked about, again, all the negatives, when you sit back and you think about what is this child's individual strengths and needs, what is that hardware problem and what is the software problem? How can we change that trajectory for them? It becomes this entire sort of paradigm shift in how we need to think about treating these children. And I'm very much a treat them as a family. Continuing through the path of just ripping people out of their homes, not, you always want a child to be safe. Safe is always important. But can we provide treatment for the parent alongside maintaining stability in their home? Because if we can treat a parent in recovery with the therapeutic services, like how to parent this child, how to respond to this child, how to meet some of their psychosocial needs, like housing and jobs and safety, we may have better success in the entire system for both the parent and the child than continuing to try to address things individually. And so as many options that we can keep a child safely in their home with their caregiver without change will lead for better outcomes for all, as long as we can meet that safety part. A lot of these parents are very challenged, even parents in recovery are very challenged by their children's behavior, and they often feel guilt and overwhelmed, or even kinship caregiver parents may feel very overwhelmed by the hyperactivity or how to parent these kids, because they may struggle to listen, they may struggle to sit still, those breaks are missing. So you really have to approach this in an attachment-based family therapy type world that really builds attachment. So there are several attachment-based sort of therapies that really help a parent and child connect and really be together as a unit. You have to teach the child how to take direction. You have to teach the parent how to make eye contact and listen and give a direction in a way child can handle it. You have to talk about not giving 3 commands at once and giving 1 command at a time. That has to be part of a parental unit. So family therapy is very, very, very critical in this population. Individual therapy, the child may need individual therapy, but this is where you have to be very aware of the child's needs. Most traditional therapies are cognitive based, and you have to understand if the child can do that cognitive level of care. A lot of times, some of these kids have a lower cognitive capacity that the best therapy might be play therapy, or you actually have to teach them impulse control, or you have to do social skills work to help them read faces. You have to really, really identify the specific needs and teach that service, because most children may not be able to handle more of the cognitive, in-depth sort of experiences that may be part of that. These kids often need to have their hearing, vision, and language checked. And I do mean language, not speech. Speech is what comes out, right? But language is more complex than that. Did they hear it the correct way? Again, because these are disorders of processing, what they see and experience can have vastly different sensory outcomes. They may not understand the tone. They may not understand the pragmatics of it. Those become important assessments too. And you have to teach children what that means, and they may need practice in those areas as well. So that is also very critical. They have medical needs. Maybe they are not sleeping. Sleeping is huge. Not sleeping makes all of these things worse. So sometimes we have to stick with basic growth, nutrition. I write so many speech, occupational, and physical therapy evaluations for these kids. They need tons of assessments and services. Many of them need IEPs and 504 plans, and you have to really know what their strengths and weaknesses are to build those services. I'm a big fan of neuropsych testing, and I believe that every child with in utero exposure needs neuropsych testing, not just psychological testing or psychoeducation testing, but the in-depth testing to really know this child might do better with visual, this child might do better with auditory, this child processes information at this level, because we have to build the treatment plans around their success. If we try to build a treatment plan where they don't have those neurons, right, they can't just regrow them overnight. They take years to regrow them, but we have to start with what's there to build that out. So we really need a very good cognitive profile of where their strengths and weaknesses are. And finally, I do believe there is a role for medication in some of these kids. Some of these kids are so wild they cannot sit still, and that creates a safety problem or even a learning problem secondary to the fact they can't sit still. And many of them are depressed and anxious. And so it is important that we get them to the right thing, but you have to, as a prescriber, really understand those neurons might be missing. And it becomes a little bit of a challenge, because if you dump all this serotonin from SSRIs and all this neurotransmitters from norepinephrine, dopamine into kids without those brains, you can see worsening agitation, worsening hyperactivity. And so you have to approach it with an understanding. It's an understanding very similar in autism populations or IDD populations, that medicines that act specifically on the brain are going to be less efficacious because the neurons aren't there. You're going to have a higher risk of side effects, especially movement risks and those paradoxical responses. Often you have to start at lower doses. It may not be that they don't need a higher dose eventually, but you have to go much slower with it and start lower. You have to know how the medicine acts. The ones that are acting primarily on the cortex, if that cortex is missing, it's not going to work. But you also have to understand which might be less centrally acting. And this is where I give an example with your ADHD medicines. Wellbri, Strattera, stimulants tend to have a lot of cognitive activity, but something like Intuniv or clonidine, Catapres, may have more peripheral acting because they don't affect the brain directly. It can have more of a peripheral effect. Sometimes antipsychotics have more of a peripheral effect on impulse control than the other ones do. And so you really want to, if you know that your child has been exposed in utero, you want to make sure that that's being taken into consideration with medication trials. And it does become a little bit more trial and error, but understanding that they're not going to respond the way you think you're going to respond. And if you aren't making progress, to stop and go a different direction can be really, really helpful. And I always listen to parents, that medicine's making it worse. It probably is. It's time to stop and rethink this, because it's not straightforward ADHD. It's not straightforward depression. And sometimes you have to also go back and work together with therapists and think about how we're matching the needs. Is this something that would be better approached with therapy versus medicine or not? And again, we can talk more about that at length, but it is a very unique sort of thing to address. And so finally, I have seen so many kiddos have such great success. I know that this works. I know this multifactorial approach works because I've seen it, and I've shared success stories with my families, from kids graduating from school to getting better. But it really does require that me as a provider, as well as I think the parents, just have a different understanding and approach to this, and realizing that these kids truly are different and unique, and they're their own little subspecialty population that we have to adapt to serve, because they will not adapt to our fancy little DSM-5 if we don't start thinking outside the box. And I feel forever shaped by my fabulous families and dedicated caregivers of these kids. And I know there are success stories out there, and I want more people to have access and understanding to that, because this is a huge, huge need, at least in West Virginia and many other parts. So with that, I'm just gonna take questions. I hope this was helpful to you. I'm sure you all do have questions, but any thoughts, questions, just come off mute, put it in the chat.
So I had a question regarding what you see as a correlation of autism diagnoses with in utero exposure, because that's something in my experience I have seen working in just in with children, but as well with the Title 19 waiver population, that I have kind of questioned some of those diagnoses of autism because of the biopsychosocial history that we were given.
Well, so there's certainly some emerging data that there may be higher rates of autism across that, but I think you're getting back to answering the diagnostic question of what's autism versus what's an intellectual disability and what is a neurocognitive disorder. And ultimately, when you gauge the difference between those two, it really comes down to social functioning. And I will say a lot of these kids actually have advanced social functioning. It's the other areas that they're really struggling in. And so, you know, I think that becomes, again, it's a very subspecialized area to diagnose autism in utero, in intellectual disability to begin with. You really have to look deep to assure that it truly is a decline below just, and beyond just the social thing in that differential. And I will say, I don't think people, I personally don't see it being looked at enough, but part of it is we don't have another diagnosis, right? That diagnosis I put forward out there is in back of the book. So I see a lot of kids being diagnosed with autism, and I personally don't think it's autism. I think it's the neurocognitive piece that we talked about with in-utero exposure, but that doesn't technically exist. And you have to really, you know, and I've labeled kids that way and put the non-specified, and people are like, what the heck is that? And you have to like really reach out, because a lot of times people will go ahead and give the autism diagnosis because it gets services, but certainly, especially with opiates, when you see some of that high level of sensory and motor coordination, you absolutely see kids with repetitive behaviors and low IQ and social deficits. But has most of them truly shown that the social deficit is below what's expected for their cognitive ones? I frequently don't see that, but we are absolutely seeing an increase of that diagnosis. But I think it's because we have not really diagnostically given another term for this, because you can't, I mean, in many ways you think about treatment, a kid with this needs as much services as a kid with autism, but I don't think it's biologically the same. Do I have hard data to separate that? No, because I don't even think there are enough people doing these great assessments to separate it out. And I mean, I'll be honest with you, I didn't know anything about this when I graduated. I don't think people are talking about it even in child psychiatry fellowships outside of like areas that are affected. I didn't know anything about this. I was still giving the kids the 16 laundry list diagnosis because that's all I could get them to meet. So yes, I think you're absolutely right. I think autism and this are neurocognitive disorders. I think they have a lot of overlap and some similarity, but we have to do a better job and have more providers able to differentiate those things. And we need a better diagnosis to be giving them, because, I mean, being all pragmatic, sometimes it's better these kids get an autism diagnosis, even though we kind of know that doesn't fit, so they get the services they need. But that, as a scientist, you know, that's a terrible answer. But I think it becomes a very pragmatic one because their needs are so significant. I wish that in the next TR version that comes out, we get a more solid way to start categorizing this, but we do not have this now. But you're absolutely right. That is what is happening.
Thank you for your feedback.
Thank you so much, Jocelyn, for that question. And thank you. I just wanted to say thank you to Dr. Swagger for such an interesting and important topic that you have done today. Appreciate that. Does anybody else have any questions? Don't be shy. It's a safe space in here. Like we always want to, you know, tell you guys, and you can chat in questions too if you feel more comfortable doing it that way. But we'd love to see your faces and hear your voices ask the question mostly. No questions? Comments? Feel like a teacher. People are thanking you a lot of information to think about too. Absolutely. And if you do have any questions, please do just reach out to myself or Micha. You can get in touch with Dr. Swagger if you have any questions on this topic. But if nobody has any other comments or questions right now, we'll just go ahead and just give the final announcements. We really appreciate your guys' time today. Thank you so much for joining us. And our next time we'll meet will be July 19th And Dr. Lillard will be discussing self-care. And we also have a case that day. So we're excited about that too. If you have any other cases you want to submit, please do. And we hope you guys have a great rest of your week. Thank you.
Thank you.